Good evening, everyone. My name is Kate Bowden. I am one of the attorneys at Disability Rights Rhode Island, and we are so pleased to welcome back Jonathan Martinis tonight for our next workshop in a series of workshops on supported decision making. Jonathan is the Senior Director for Law and Policy for the Burton-Blatt Institute at Syracuse University. He represented Margaret Jenny Hatch in the Justice for Jenny case, the first trial to hold that a person has a right to use supported decision making to make her own life choices instead of being subjected to a permanent full guardianship. Jonathan has led projects across the country about supported decision making. He has educated and trained tens of thousands of people with disabilities, their families, and professionals about supported decision-making theory and practice. And he has written or co-written over 40 publications on this topic. I must say that I have been wowed by Jonathan's workshops, and I am so excited to hear what he has to share with us tonight. And I will turn it over to you, Jonathan, and take it away.
Thank you so much, Kate. And as usual, I think there is no way I can live up to that introduction. Before we even begin, I want to apologize for the poor quality of our video tonight. It's entirely my fault, or perhaps more truthfully, Mother Nature's fault. I am speaking to you from a hotel room. If you saw the news recently, you maybe heard about the 50-mile backup due to a snowstorm that closed Interstate 95 in Virginia. My house is pretty much right in the middle of those 50 miles. We've been without power or heat since Monday. Today, we finally gave up and came to a hotel, the first one we could find with Wi-Fi. So the poor lighting is part of the deal. I apologize, but we'll muddle through together because today we're going to talk about what I think is one of the most important parts of supported decision-making, ways that we can use supported decision-making to make people's lives better. Ways that I call, broadly speaking, healthcare and life planning, those day-to-day things that we have to do to take care of ourselves, to take care of our health, to take care of our finances, and ways that supported decision-making can help trace a through line all through life to ensure that we have the best quality of life. So with that, let's begin. I'm going to share my screen. And we'll begin. And as always, we begin with what I call an article of faith. And the article of faith for this presentation comes directly from the Americans with Disabilities Act. It says that physical or mental disabilities in no way diminish a person's right to fully participate in all aspects of society. Note that phrase, all aspects of society. It's shocking that it took until 1990 to say that. I've always said that the Declaration of Independence in 1776 said all men are created equal. It took until 1864 to say all men, whatever their national origin are, have equal rights. It took until 1919 for women to have equal rights, at least to vote. It took until 1964 for people of all races, creeds, colors, and genders to be said they have equal rights. But it wasn't until 1990, 214 years after the Declaration of Independence Act, where people with disabilities were qualified fully and equally as people. But that's where we are, and that's what the law says. We now know that people with disabilities have full and equal rights all through society. And here's something else we know, is that self-determination, that people who have more self-determination, who make more choices, who make more decisions, who have more control over their lives, have better lives. These are the two articles of faith for this presentation. One, people with disabilities have full and equal rights to do everything everyone else does. And two, people with disabilities who make more choices, who exercise more self-determination, have better lives, meaning that they will be better able to fully and equally access all aspects of society. In fact, we know from about 40 years of studies that people with disabilities who have more self-determination, remember, who make more choices, are more likely to work, more likely to make more money, more likely to live independently, more likely to be more integrated in their community, more likely to be healthier, more likely to be safer. So the key to this, the key to full and equal participation is this: having more self-determination. And as we have discussed throughout this program, a great way to get to self-determination is supported decision-making. The definition on your screen that I have told you time and again, I don't like very much, even though I wrote it, of supported decision-making, saying that people with disabilities work with friends and family members and professionals who help them understand the situations and choices they face so they can make their own decisions, which really just means supported decision-making is getting help when you need it from people you trust to do the things you have to do. And that's it. Supported decision-making is getting what you need to do what you have to do. It is something that people without disabilities do every day without even thinking about it. I gave a presentation earlier today for Nebraska, and I heard this great mother and daughter talk about how they use supported decision-making. And one of the first things they said is, we've been doing this for years and we've never even heard the phrase until recently, supported decision-making. And I said, right. Because who calls it supported decision-making? It's just life. We all get help to make decisions every day. So that's what supported decision-making is. And here is what supported decision-making can do. We are seeing the research showing that people who get support to make decisions, who make their own decisions with support, have more self-determination. And again, as I've said time and time again, that's not rocket science. If I'm making my own decisions with support from you, of course I have more control over my life than if you made decisions for me. But studies are bearing that out. What I've told you about and what you see on your screen is the results of a pilot study that I was part of in Virginia, and I'm working to get a publication out on it as soon as I can. But what we did there was work with 10 young adults with intellectual and developmental disabilities, empowered them, taught them about supported decision-making, and collected data on how it impacted their lives. And what we found after a year's worth of this project and interviews with them and their supporters and review of qualitative and quantitative data was that across the board, all of the ones who used supported decision-making were more independent, more confident. According to everyone, were better at making decisions and made objectively better decisions. And even in the middle of a pandemic, the majority of them said they were doing more things in the community, being with more people, having more activities, and all in all, having a better quality of life. And maybe that's why what we're seeing is time and again, pretty powerful entities are endorsing supported decision-making. The U.S. Department of Health and Human Services funded the National Resource Center for Supported Decision-Making that I'm one of the directors of. The American Bar Association has strongly endorsed reviewing of state laws to enhance use of supported decision-making. The National Guardianship Association says we should try SDM before guardianship. And powerful private organizations like the Autistic Self-Advocacy Network, the ARC, the National Alliance on Mental Illness, the AARP, have all in some way or another come out strongly in favor of SDM. And yet, especially when we're talking about quality of life, even with that, and even with all that data, particularly when it comes to healthcare, what we're seeing is that people with disabilities are not having full and equal access. In fact, what we've seen, the US Surgeon General found that people with disabilities, even when they have more medical conditions, statistically speaking, than others, still are either getting overtreated or undertreated, or getting poorly diagnosed or poorly treated. And that could be because in a study asking, what was the first prompt for guardianship? What was the first thought? The number 3 identified source was doctors. That doctors are making assumptions that people cannot manage their own healthcare or should not manage their own healthcare, leading to guardianship, leading to loss of self-determination and loss of rights. So what we have found is that, and what we hear time and again from doctors, I've presented to doctors many times, and what I hear from doctors often and then heard back from parents is that the reason they recommend guardianship, or the reason they feel that people with disabilities can't be a leading part of their healthcare, is because they cannot engage in what's called informed choice, quote unquote. So when I hear that, I went back and did some research on it, on what informed choice is, and found some research from the American Medical Association, the professional association for doctors. And sure enough, they identified informed consent as the heart of the doctor-patient relationship, the most important part. And the way they describe informed consent is this: information exchange. I tell my doctor what my symptoms are, what my problems are, how I'm feeling. And then the key part is the doctor is supposed to give the patient information. Give the patient information about a diagnosis. Say, this is what I think you have. This is what I think you should do. The patient is then supposed to receive that information, understand it, and then make a choice on what to do, whether to follow that advice, whether to not follow that advice, whether to ask more questions, and communicate that choice to the doctor. So it's all about information exchange. I tell the doctor how I'm feeling. The doctor tells me what I'm thinking, what he's thinking, pardon me, or she is thinking, or what the diagnosis is. And then I say, okay, doctor, I'll do what you recommended. Or I tell her that I won't do what she recommended. Or I'll think to myself, I need more information from her about what she recommended. So it's all information from me to you, from you to me, and then choice by me. That's informed choice. Well, what we know and what we should expect is at every level of that exchange, we can use supported decision-making. We can use support. I can work with a supporter to help me explain my symptoms to my doctor. I can work with a supporter who can explain to me what the doctor is saying to me, or can help me ask the doctor to explain it in more plain language. And then I can work with a supporter to make that decision. So the key part here is that we have to realize, and doctors have to realize, that informed consent is not a black or white issue. Ability to make decisions is on a continuum, like every other ability. Think about it this way. When the doctor tells me, when I go to the doctor, and I'm a big baby when it comes to the doctor, I say, please, I feel terrible. I have the flu. Help me feel better. And the doctor says, okay, I want you to take one of these pills a day for 6 days. Gives me a classic Z-Pack. I say, I love Z-Packs. They always work for me. I have no idea what's in that Z-Pack. I'm not going to read those tiny letters in the packet that comes. So what I do is I trust my doctor. I understand my doctor thinks I have the flu or has strep throat and wants me to take this Z-Pack. And I say, yes, I will. But here's the thing. I'm not the doctor. I have no knowledge of really what's in that Z-Pack. I have no knowledge of how it works. So consent, informed consent, doesn't require me to know everything. If it did, I would have to be a doctor. It requires me to be able to receive the information and understand it with the support of the doctor. So the doctor recommends Z-Pack, the doctor tells me how long to take it, and the doctor says, this is what it'll do. I may not know any of that, but I can trust the advice of my doctor. And as a result, I can give informed choice. The information that came from my doctor helped me get what I needed to make that choice. In other words, that means that using supported decision-making gives us a flexible way to incorporate that informed choice process, because there are many ways I can understand. There are many ways I can get information that I need, and it can be on the spot. If I have a supporter there, it's going to make communication more streamlined. It's going to improve communication. How many of us find that it's helpful to have a third person in the room? I've had my wife in the room with me when I have gone to the doctor, just to make sure we have good open communication and understand everything we need to understand. That's something that's helpful, and it improves communication, and it increases the role of family and friends and professionals to lead to a better, more important, more effective decision-making process. That's what supported decision-making is. And as the Administration for Community Living, part of the US Department of Health and Human Services, said, it's different for everyone. I stressed that the very first time we talked with each other. There is no one way to do supported decision-making. We all do it. We all need support, and we all use that support in different ways. So I may do work best one-on-one with my doctor, asking my doctor a bunch of questions. Can you explain that? Can you explain this? Can you put this in plain English? I may do better because I'm nervous with the doctor, having someone come with me to help explain to me what the doctor is saying and what I'm saying, help the doctor understand what I'm saying. Maybe better for me not to make decisions on the spot, to receive information from the doctor, take it home, discuss it with someone, and then make a decision. As ACL says, with supported decision-making, the possibilities are endless. We look for the thing that works for the person. And if we do that, we can enhance people's control over their life, their self-determination, especially involvement in their healthcare. I mean, think about it. People who would otherwise be assumed they cannot use informed choice and be pushed into guardianship would now be able to work with supporters, understand their choices, make informed decisions, and manage their healthcare with the help of someone else. Doctors who might otherwise be skittish about providing healthcare, might otherwise recommend guardianship, can now work directly with the person. And what we know from studies is that having better communication with patients leads to better outcomes and leads to greater satisfaction in their job and less burnout from doctors. So it's exactly what the doctors want. And family members and friends and others who might otherwise be concerned about the person, might otherwise be thinking they need to seek guardianship, can now become supporters and be part of a working process to enhance that person's healthcare, which, as we know, is a direct result of enhanced self-determination. So all of this results in a person having more control over their healthcare, more control over their life, more opportunities to make decisions, and greater involvement in their healthcare. And we can do it easily. I get all of the time from doctors when I have this conversation, well, we can't do that. We can't have that third person in the room because of Hipaa. Sure, you've all heard of Hipaa, the Health Insurance Portability and Accountability Act, where they say, oh no, we are required to keep things private. We cannot have a third person in the room. And when I say that, when I hear that from doctors, I always get confused. Now, what I tell them is, you know, every time I come to the doctor, every time I come, every time you come, every time any of us goes to the doctor these days, we are given a big, long form to fill out on privacy. It might say privacy notice, it might say Hipaa release, it might say notice of privacy policies, but they all say the same thing because they're all based in Hipaa. And what they say is, under Hipaa, we can't share your information with anyone else. We are not allowed to share your information with anyone else, except someone you choose. There's always a line. There's someone I want you to share my information with, like my other doctor or my family members. So what is the difference between sharing information as permitted by a Hipaa form and supported decision-making? There is no difference. Supported decision-making is just sharing of information. It's sharing of information between doctors and patients and doctors and supporters. So you can take that Hipaa form and they all give you a place to write in a name that the doctor is allowed to share information with. And you can write right next to it, to help me make decisions or for decision-making purposes. And just like that, you've given the doctor authorization to share information, to engage in supported decision-making. If you don't want to use the doctor's form, you can make up your own. There are models at supporteddecisionmaking.org, and all of them are Hipaa compliant because what we need with Hipaa is simply permission. Because, you know, a doctor is right when a doctor says they can't share information. They're absolutely right. So if a doctor says without permission, I can't share this information, they're correct when it comes to Hipaa. But here's the thing about Hipaa. Hipaa rights belong to the patient, not to the doctor. It means the doctor can't say, I won't do this. What Hipaa says is the doctor has to say, I won't do this unless you give me permission. Hipaa rights belong to me, not the doctor. So the doctor, he or she, cannot share my health information unless I give that doctor my permission. And that's what Hipaa does. So Hipaa does protect your right to privacy. Hipaa does prevent doctors from sharing your information. But Hipaa also gives you the right to share your information and to tell the doctor to share your information. That's called waiving your Hipaa rights with regard to a particular person. I can say, I waive my Hipaa rights for Kate Bowden, because I want Kate Bowden to be my supporter. I want Kate to come to the doctor with me so that I can understand the doctor better, the doctor can understand me better. So even though, doctor, under HIPAA, you can't share my information with Kate, I am waiving my HIPAA rights so that you can share it specifically with Kate. So if we look at it that way, then that information sharing leads to supported decision-making. I share my information with the doctor, or I work with Kate to help me share information with the doctor. With permission, I want Kate there, remember. I'm asking Kate to help me explain my situation from the doctor. The doctor then shares information with me. Here's what I think is going on. Here's what I think you should do. Kate is there to help me understand that and ask questions. And then Kate and I might want to talk this over about what I should do. Help me figure out if this is the course of action I want to take, which medication to take, whether I want to take any medication. If it's a big decision like surgery, whether I want to do that now or get a second opinion. I then make my decision, and then I'm able to communicate that, perhaps with Kate's assistance, to the doctor. That's what supported decision-making is. Sharing information, helping me share information. So you can go right to the doctor, like I said, and you can change that HIPAA release. You can write on that HIPAA release. I also authorize you to share information with Kate to help me make decisions. Or we can simply write our own form, and there's language on your screen. Steal that language if you want. You can make an authorization to give the doctor permission to share my information with him or her. You can also create a different release. And again, here's information on your screen. This is a very formal one where we can write this up and we can say to the doctor, going forward, instead of having to change that form every time I go to the doctor, we give the doctor one agreement that says, I authorize you, I authorize Kate to come with me, and I want Kate to be just like me when it comes to my medical records. That means I can see my medical records, Kate can see my medical records. And you can even quote HIPAA. The language I give you on your screen specifically quotes HIPAA. It says, I'm releasing you, I'm giving you permission, I want you to share information with Kate so she can help me understand, make, and communicate my own medical decisions. And we can do that even more formally. We can create a power of attorney. Powers of attorney are great things. I always recommend people have powers of attorney because they say what should happen if, God forbid, something bad happens. So on your screen, again, is language I've used in many powers of attorney. What they say is they build in supported decision-making. So a power of attorney says, God forbid something happens with me and I can't make decisions. I want someone else to make decisions for me. I want Kate, I want Kerry Walker, it's just a name I see on my screen right now, or Bruce Conklin to make decisions for me if I can't do it. But we can include in that language that incorporates supported decision-making. Yes, I'm giving you power to make decisions for me, but to the maximum extent possible, you've got to give primary consideration to what I want. Even though it's your decision, you've got to check with me and check with what I want, and to the maximum extent possible, do what I think is right. That's one way. For medical care, we can do that even more specifically. I know there's lots of words on your screen, but this comes directly from a power of attorney I did for healthcare. I think it's very useful language because in this one, the person we were working with had really specific preferences. And what we did was we said, God forbid something happens to me, you, it was her mom in this case, have the power to make decisions for me. But you're going to make those decisions in a way that I'm telling you now. So if one day I'm incapacitated, you're going to use these decisions that I'm making as a guide. And it was things like, I never agree to psychotropic medications. I always want extraordinary measures. And what we said was, in making any decisions about my healthcare, you have got to check with me first. If I haven't given you specific instructions, you got to check with me first. And you're going to do what I want you to do. And if I'm unable to say what I want, if something horrible has happened and I can't say what I want, you have to make the decision I would have made, that you would think I would have made, even if it's not what you would have done. That's the essence of supported decision-making right there, where ahead of time, you can make your preferences known. You can say, someday I may not be able to say what I want, but right now, if that day ever comes, what I want you to do is make decisions consistent with this guide. I do want this medication. I don't want that medication. I do want this kind of treatment. I don't want that kind of treatment. That brings, even when I can't make my own decisions, it gives me maximum ability to be involved in it. And that works even if a person isn't incapacitated. Here's yet more language we've used. Because what if you know that you're able to make decisions now, but you still want help doing it, right? Because you can do a power of attorney or a medical advance directive, they're sometimes called, where I say, God forbid I can't make medical decisions, I want you to do it for me. But then we can also say, even if I'm able, while I'm able to make decisions, I still want your help. I still want your help in making it. So look at this language on your screen. When my agent, you, does not have power to make my decisions, when I'm still making my own decisions, I still want you to come to the doctor with me. I still want you to help me understand the situations I face and decisions I have to make. I still want you there so that I'm able to make decisions to the maximum extent possible. I'm able to be the final decision maker with your support. That brings us to a point where we are in, regardless of our condition at that time, maximum control of our healthcare. In all of these are all using supported decision-making one way or another to ensure that the person has maximum decision-making authority throughout his or her life. So I think that is a great opportunity for us to move forward in using supported decision-making to make people's lives better. Kate, was there a question? You're on mute, Kate.
Can you hear me? We had a question about, what do you do if the doctor questions the person's capacity to even understand and use a power of attorney type document?
I don't have a lot of patience for that. Here's the thing. Every state law says this. Every person is presumed to have capacity until they are found not to have capacity. So if I've got a valid power of attorney that I present to my doctor, and my doctor says, hey, I don't think you had the ability to sign that power of attorney, to me, that doctor has two choices. Go to court and seek guardianship, or go to court to seek to invalidate the power of attorney. I do not believe that doctors do or should have the authority to go behind a power of attorney without taking the steps to follow it. In fact, in some states, I don't know Rhode Island's law on this, but in some states, there are even penalties for ignoring a valid power of attorney. If they think a power of attorney was gotten through abuse or neglect or exploitation, file with Adult Protective Services, go to protection and advocacy, but do something, don't just say no.
I'll take it up a notch. What about situations where the person doesn't communicate with or understand language?
Hey man, that's a biggie to me, because that assumes that communication is solely a form of spoken language. There are a million ways to communicate, a million. And I know, Kate, I'm speaking to you and you know this, but in our world, in the protection and advocacy world, we have seen so much communication. You know, that study I talked about in Virginia, of the 10 people we worked with, 5 were what used to be called nonverbal. I just call it non-traditional communicators. They had other ways of communicating.
Mm.
Some had spelling, some used signs. And what I have to do, what my job is to find that person's language, not to judge that person's language. In a very personal note, my uncle had cerebral palsy, and he couldn't speak. My grandfather in the 1950s, mind you, fought for him to be educated so that he could use a letterboard to spell. And God forbid anybody, and God help anybody who questioned Uncle Bob's communication, even though he couldn't speak. So if a doctor has the gall to say you can't make decisions because you can't speak, there's a whole lot of people who'd have a whole lot to say about it. And I have to imagine Disability Rights Rhode Island would be at the front of that line.
Thank you. All right, I'll pop back out.
Okay. So these powers of attorney give people maximum opportunity to make their decisions and be involved in the decision-making process. But that's not the only healthcare procedure where we can use supported decision-making. So many people are on what we call Medicaid waivers, and Medicaid waivers are phenomenal tools to help people live and thrive in the community. But to be part of a Medicaid waiver, you have got to be provided with what they call person-centered planning. And I pulled what you see on your screen directly from Medicaid's guides and regulations. And they talk about what person-centered planning is. Take a look at what it's supposed to do. A person-centered plan must address health and long-term services and supports in a manner that reflects individual preferences and goals. The guide goes on to describe how the person should have a person-centered planning team made up not just of his or her providers, but also of family members and friends and others who understand the person, so that the person is able to communicate with support from his or her team what's important to him, what's important for her, where the person is now, where the person wants to go, what the person wants to do, and what the person wants to be. The idea is the team helps that person receive the information he or she needs to make those decisions, to understand his or her options, so that that person can decide what kind of life the person wants. That's just supported decision-making, isn't it? It's one more example of how I can get what I need to make decisions by working with a team. And person-centered planning is perhaps the classic example, because look at all of the things person-centered planning is supposed to encompass. A person on a Medicaid waiver is supposed to have goals, objectives, and services around community participation, employment, income and savings, healthcare and wellness, education. I've seen many that include specific sections on self-determination. So this is a tool, a critical pathway for independence and community integration. And what do we know is the key component of that? Self-determination. And how can we get to self-determination? We get there with the person making decisions. We get there with the support of our team. And there's so many other ways to get that support. I hope that many of you have identified and you're working with your local Center for Independent Living, or CIL. If you're not, I strongly recommend you find your local CIL. There is a website right there where you can locate the one closest to you. I think CILs are wonderful agencies, because the whole point of the CIL is to be in the community and help people live independently in the community, help people have equal opportunities, have more self-determination, and have more respect in the community. In other words, the entire mission of the Center for Independent Living is to fulfill that article of faith we started with, to help people have full and equal access to their communities and opportunities. And CILs do that through the supports they provide. Here are just some examples of what CILs can do. They can provide independent living skills training, peer counseling, psychological and mental health services, housing services, and quote, other services that will help people function in the community. So why shouldn't that include support? Why shouldn't that include decision-making support? Think about all the things you see here. These are all directly related to self-determination, choosing how and where I want to live, choosing the assistance in medical and mental health care I want. And the beauty of it is that the majority of CIL employees by law, must be people with disabilities. So if you go to a still, there's a very good chance that the person with disabilities will be able to work with other people with disabilities who can provide information and support on using things like supported decision-making, because they use supported decision-making in their lives, because they have developed those circles of support, those teams around them to help them learn, identify the support they want, identify who they want the support from, and to put that support in place. Something else I want to talk to you about medical care is what I think is a new development. You may hear the phrase shared decision-making, and it's important to talk about this because this is something that's increasingly coming online, specifically in the mental health realm. And to understand shared decision-making, we first have to understand choice. Now, when I go to the doctor, remember we talked about going to the doctor, the key part of the informed choice process is me understanding what the doctor recommends and me choosing whether or not to do it. I get to make an informed choice of whether to follow the doctor's advice or not. And you know what? I have every right not to follow the doctor's advice. It may not be the best decision in the world, but I have that right. There's even a phrase for it. Doctors calling it making a decision AMA, or against medical advice. So if I make a decision AMA, which is my right to do, it means I listened to the doctor, I considered what the doctor said, and I just chose not to do it. Maybe I didn't want to get surgery. Maybe I wanted to try a different medication. Maybe I just wanted a second opinion and wasn't ready to jump in with what that doctor said first. So I have the right, everyone has the right to make decisions AMA. Recently, there's been a push with regard to people with disabilities about AMA. And remember, there's nothing wrong with making decisions AMA. And unless you are a minor, where your parents make decisions for you, or you're under guardianship, then you can make those decisions AMA, just like everyone else. But recently, we've seen a new phrase called shared decision-making, or shared DM, sometimes even called SDM. And here's how shared decision-making works. In shared decision-making, the person and the healthcare professional and any supporters talk about the issue, just like with supported decision-making. Information is given, support is given, so that the professional can give his or her advice. The doctor can say, I think this is what you should do. I think you should have this treatment or this medication or this course of action. And then the doctor and the person try to reach an agreement on the decision. And the person can decide what to do. Yes, I do want to take that medication. No, I don't. Yes, I want that treatment. No, I don't. But the only time the doctor will follow or honor that decision is if the doctor agrees with it. In other words, let's say the doctor recommends that I do an inpatient stay, or let's say I have done a short inpatient stay because I had a mental health crisis and I have been found now to be stable. In shared decision-making, the doctor may say, you know, I think you might want to stay on an extra few weeks to get medication. And I can say, you know what, I think even though it's AMA, I think I want to be discharged, as everyone's right would be. Under shared decision-making, I wouldn't be allowed to make that choice because the doctor didn't agree with it. The key part about shared decision-making is even people not under guardianship would lose the power to make decisions AMA, because my decisions are only honored if the doctor agrees with it. Now, I have to say, even though I have concerns about shared decision-making, and I think you can guess what those concerns are, that people with disabilities don't have equal rights in that decision, there's nothing wrong or illegal about it if that's what you want to do. I've had many people with disabilities say, I like shared decision-making because it gives me an important check, especially if I'm in a psychological crisis. So there's nothing wrong or illegal about it. I just want you to know that it exists, because you may be offered SDM or shared decision-making, and know that there is a difference between shared decision-making and supported decision-making. One size does not fit all. It may work perfectly well for you, but ask questions about any healthcare. That's part of supported decision-making too. Let's talk about another kind of healthcare. And this is particularly important for young children and young adults. how to get supported decision-making through the Medicaid system. If you are under 21 years old or under 26 and receiving foster care, these are the 5 most important letters you can imagine. Anyone under 21 getting Medicaid needs to know, and every parent who is a parent of someone who is under 21 and receiving Medicaid needs to know about this program. And it's called EPSDT, Early and Periodic Screening, Diagnosis, and Treatment. To tell you about EPSDT, I first have to tell you about Medicaid a little bit and how Medicaid works, okay? I'm sorry, my slide slipped. I first have to tell you about how Medicaid works. Medicaid is a contract between the federal government and a state government. So Kate, let's assume for a second, I'm talking right to Kate Bowden because she's had the unfortunate experience of being the moderator here. So Kate is going to be the state of Rhode Island for this conversation. I'm going to be the federal government. Here's how it works. I, as the federal government, say to Kate, who is Rhode Island, hey, do you want a whole lot of money? Millions and millions and millions of dollars. And if you want that money, Rhode Island, you have to agree to be part of the Medicaid system. Every state has agreed to be part of the Medicaid system. So here I am, I'm the federal government. I want to give you, Kate, Rhode Island, this dump truck full of money. But if you accept this money and if you become part of the Medicaid system, there is a whole bunch of things you have to do. There's services and supports you have to provide. We're going to call it like if you ever had gone to a Chinese restaurant, there's always a column A, there's always a column B. Well, column A has a bunch of things that you're going to have to do if you take this money. Okay, you have to do all of these things in column A. There are things like assistive technology, maternal and child health, occupational therapy, physical therapy. They're all in column A. You want my money? You have to do them. And now I say to Kate as Rhode Island, you know what? I've got a second dump truck full of money. You don't have to take this money to be part of Medicaid. It's your option. You can have this second dump truck full of money, but if you do, there's stuff you have to do in column B. These are things you don't have to do to be part of Medicaid. I'm offering you some additional money to do them. You can do them, you cannot do them. This is classically things like dental care. Okay, so you can do it or not. So Kate, you can have the second dump truck full of money or not. It's all your choice. But here's the thing. If you don't take the second dump truck, you don't have to do column B. You're going to have to do column A regardless if you're part of the project, but you won't have to do column B unless you take the extra money. Many states don't take the extra money. Okay, there are many states that don't do things in column B. Now, here's the cool part. If you're on Medicaid and if you're under 21, and it doesn't matter how you're getting Medicaid, if you're getting it through the state plan, if you're getting it through a waiver, if you're getting it through an HMO plan, as long as you're on Medicaid and you're under 21, you are already getting EPSDT. You don't have to apply for it. You don't have to ask for it. You just get it when you're under 21. So if you are under 21 and getting EPSDT, you automatically do. Then you have a right to everything in column A and everything in column B, whether or not Rhode Island provides the stuff in column B. So even if Rhode Island said, we don't want to do the stuff over here, we're not taking the extra money. If you're under 21 and you're a Rhode Islander, you get all the column B stuff. So anything anyone can provide anywhere under Medicaid, you have a right to if you're under 21. Here's the simplest example I can give you. When I was with the Virginia Protection and Advocacy System, Virginia did not provide dental care under Medicaid. Dental care is a column B issue. Virginia did not take the money. So the only dental care people with Medicaid could get was their teeth pulled, extractions. So there were hospitals and institutions full of people with intellectual and developmental disability who had no teeth because that was the only dental care they could get. Okay, Virginia didn't have to provide dental care. They didn't take the column B money. But Virginians who were under 21 got dental care because of EPSDT. You get everything in column A and column B. I had tons of Medicaid cases where we got things under EPSDT that never would have been gotten for an adult. Specialized equipment, specialized bikes. We once got a jungle gym covered because our client had cerebral palsy and needed to do stretching exercises. And the doctor determined this was the best way to ensure the stretching exercises. There were specific diagnoses and a specific prescription for specific exercises that could only be done on this specific piece of equipment. It was covered under EPSDT, even though Virginia did not cover therapy equipment under Medicaid. So that's what you need to know about EPSDT. I'm sorry for the long-winded description, but it is absolutely the greatest healthcare program for kids on Medicaid. If a kid is 21 or under 21, they get anything anyone could provide anywhere under Medicaid. So that means this: if you are a Rhode Islander with disabilities and you are under 21 and you have a disability that makes it harder to make your own decisions, harder to be more independent, harder to take care of yourself in a manner that society deems is appropriate and more likely to get guardianship, then you can receive therapies, supports, and services designed to increase your decision-making and self-determination. You can receive equipment designed to enhance your self-determination. You can provide services around decision-making. I'll give you a great example. When I was in the Virginia Protection and Advocacy, long before I ever heard the phrase self-determination and supported decision-making, by the way, we had a case where a young man with disabilities wanted a computer. Now, this computer was going to help this kid with his schoolwork. Okay, was also going to help him manage and plan for his affairs. But what we argued was, because Medicaid wasn't going to cover something just for schoolwork, it had to be an equipment that specifically helped address a specific disability and have a specific purpose. And what we said was this young man was going to use his computer to supervise the billing for his personal care aid, because he needed to be in charge of his personal care aid. He needed to submit the billing and approve the billing to Medicaid. It was a person-centered waiver after all. And the regulation said this person is supposed to be the hiring and supervising entity of the aid. So we said, how can you do your billing without a way to keep track of it? So we argued that this person needed the computer to maximize self-determination and maximize independence, specifically with regard to supervising his care aid. It was covered. So what you need to think about with EPSDT is ways that specific things can enhance independence and self-determination. After all, one of the major points and major qualities of the Medicaid program is to help people avoid institutionalization. So things that are going to make you more independent and better able to live and survive in the community are natural things that should be covered under Medicaid and EPSDT. I know that was a very fast move through the EPSDT process. So what I'd recommend is talking to Disability Rights Rhode Island about Medicaid in ways that things can get covered. Kate? You're muted, Kate.
Okay, sensing that we're moving on, I did notice a question that I missed. So if this is the wrong time to answer it, let me know. But someone asked if you could provide another example of a scenario where shared decision-making is exercised. I think that topic about shared decision-making was a new one for some of us. So where would that come up? And if this is the wrong time, just let us know.
Not at all. Really the place we're seeing shared decision-making in the literature is in mental health care, specifically with people who might be in psychiatric crises, who aren't under guardianship, but may have their decision-making ability compromised. It's one of the reasons why I'm so in favor of powers of attorney, or what are now called psychiatric advance directives. It gives me a chance to say, now, this is what I want to have happen if I become incapacitated temporarily or permanently. So I have a good friend who might be the leading practitioner of psychiatric advance directives in the country, and she uses them for all kinds of things with people, how to plan what happens in a crisis, to say, these are things that work for me, these are things that don't work for me, so that I'm not at the mercy, if you will, of a stranger, of a doctor saying, I agree with you, or I don't agree with you on this agreement, on this issue. A psychiatric advance directive says right out front, this is what I want to have happen. And I'm saying this while I'm perfectly competent. So we really see shared DM in the psychiatric field. However, there's no reason it couldn't apply anywhere else. I'm not going to say it's a horrible thing. I'm going to say, like everything else, it's something we should think about before we jump into. I just wanted you to be aware of it.
Okay. Is it a document like an SDM where the person signs it in advance, or is it something that the medical provider comes forward with?
Generally, the latter.
Okay.
Although you can certainly agree to it in advance. I can certainly say, I want to do this. That's self-determination right there. If I make the choice to do it, so be it, you know? But where we often see it, like I said, is in psychiatric care, generally with people in crisis.
Okay, thank you.
Getting back to EPSDT, one more place where it's tremendously helpful. And if there's parents of kids in special ed listening to me, I know you've gone through this, what I'm about to describe. You know that your kid needs something, needs a support, needs a service, needs a therapy. And the school says, yeah, we don't see that need in school. It must be just something that happens at home and we just can't do that. Or the school says, we think 2 hours of therapy or occupational or speech therapy or behavioral therapy is enough because we're just not seeing the need for it when you know your kid needs it. And really what that's code for is we can't pay for it. We don't want to pay for more therapy than that. Here's the beauty of EPSDT. If the school becomes a Medicaid provider, and that's a paperwork issue, if the school says we will abide by Medicaid rules and regs, we'll sign up for this, then anything that's medical in a child's IEP, any therapy, any arguably medical support is paid for by Medicaid. There's a link right up on your screen that shows that you can click on and you can show that and it can say that. So if a school is a Medicaid provider, then Medicaid pays for medical stuff in the IEP. And the IEP just has to indicate this is needed for medical purposes. This child needs occupational therapy, behavioral therapy, physical therapy, whatever therapy. This child needs assistive technology. This child needs a personal care attendant because all of those things can be covered by Medicaid. So what we have when that happens is suddenly schools realize that more hours are needed. They suddenly come around to realizing that wraparound services are effective or extended school year services are needed. So EPSDT can not only serve you at home, it can serve you in school to ensure that supports and services are there to help a child who is on Medicaid. But supported decision-making goes beyond healthcare. Again, when we talk about day-to-day quality of life issues, one of the biggest ones I hear about are finances. I always hear that the last great divide is money management, is financial planning. That one and romantic relationships are the two I often hear make people the most squeamish. How can they manage money? How can they have relationships? Well, let's talk about money management because supported decision-making can help you in that too. In fact, financial issues are the number 2 reason I hear why people seek guardianship. Number 1 is always safety. Number 2 is always finances. Well, supported decision-making can work with that too. Up on your screen, you see language from a power of attorney that I did with a mother and her son. This person had heard me speak and took me aside and said, Jonathan, I hear you, and I think it's a great idea, but I have to get guardianship over my son. He just can't handle money. He was 18. I don't know how many 18-year-olds can handle money, but she said he's really at risk of getting swindled. You know what? The kid had some pretty good self-awareness. He said, you know what? I might get swindled too. I don't know how to manage money. So instead of guardianship, we set a power of attorney up that let that protection happen while also giving opportunities to learn. And here's what we did. We said to the young man, we set up a budget. We said, you have this much budget. The parents had some money. So it's like $100 a week. You have $100 a week or whatever, go nuts. Learn how to spend, make good decisions, make bad decisions, whatever. But if you want to spend more than that, mom has to sign off on it. So if you want to buy a car, for example, for $20,000, you would need your mom to agree to that and sign off on it. So $100 you can spend. You can make good decisions. You can make bad decisions. You can learn to make decisions. Anything more than that, you are going to need mom to say, okay. But here's the important part. Look at the bottom of the screen. We said before mom says yes or no, before she agrees or disagrees, they have to talk about it. They have to give him a chance to explain why he wants to do this, and she has to give consideration to it. Here's why. He might be right. And if he's right, he's made a good decision. He also might be wrong. And if he's wrong, it's a chance for mom to talk with him about it. It's a chance for them to discuss it. You know what? I don't think you have the money right now to afford a $20,000 car. Let's set up a budget to make this happen. Let's figure out what kind of job you can get. Let's talk about ways to get to that goal. So the support follows with the plan. Mom doesn't just make the decision in a vacuum. She has to listen to him, and then he has to listen to her. And then we have a path forward that will hopefully help him learn to make decisions in the future. We did the same thing with banking and money. Back in the day when people still wrote checks, we created a power of attorney that said, you can write a check for up to X amount, but we put it on the check. We had the bank put it on the check. Anything more than X requires 2 signatures. We see that with businesses all the time, right? Anything above this amount requires 2 signatures. Well, we did it with a personal account. We talked the bank into doing it so that he could write a check for up to this amount of money. But anything more than that, mom had to sign off on. But just like before, look at the bottom of the screen in the bold. They had to talk about it first. Mom had to listen to the kid and understand and give him a chance to explain himself. And only then could she make the call. He might be right and she could sign off. He might be wrong and they can have a discussion about it to help him learn about it. So money is one of those great divide things. Money is one of the things that can really be the difference between being independent and not being independent. I mean, think about it. When I say things like community integration, what does that mean to you? I mean, in the age of the Olmsted case, they always said that community integration is a right. Well, so often that's looked at as not living in an institution. Well, if the only thing that community integration is about is not living in an institution, moving into a group home and never doing anything, what's the point? You're isolated whether you're in an institution or whether you're in a group home doing nothing. So when I say community integration, that's got to mean more than just where you live, right? It's got to be how you live, how you are a part of your community. Going back to the article of faith, how you are acting as a full and equal part of your community. That's the important part, right? So when we talk about it, we have to think, how do we really become part of our communities? Where do we really interact with our neighbors and friends, and where do we do things? It's at work. It's when we're getting money. It's when we're spending money. True integration is about how we live, not just the location. It's about what we do. It's about the actions we take. It's about the vacations we go on. It's about the things we buy and the things we sell and the place we work. But that's a problem if you're on benefits. So many people with disabilities are on what they call public benefits. SSI, SSDI, Medicare and Medicaid are the 4 biggest examples. Food stamps are another. These public benefits are the things that really are standing in between people with disabilities and being able to live safely. Medicaid, a waiver especially, is often providing the health care I need to live independently. Medicare, SSI, and SSDI provide those income we need to buy things we need to buy. Kate?
We got a specific question about this money issue in terms, it came up in the context of the school district, but the question was, if a school district becomes a Medicaid provider, do the healthcare services get billed to the individual or to the school department? Or said another way, does it count against the student's lifelong cap for Medicaid spending?
At the point when you are a Medicaid recipient and the school is a Medicaid provider, what you're essentially doing is agreeing to allow the school to bill Medicaid on your behalf, consistent with your Medicaid policy. The question of whether it applies to a lifelong cap is going to be a more state-specific question. And I always try to be smart enough to know what I don't know. I would again recommend talking to DRRI about that. but it is generally thought of as the school is billing Medicaid on your behalf on your Medicaid policy. But Medicaid is a great example of what I'm talking about. Medicaid is empowering. If you're on a Medicaid waiver, that is one expert I know called it is a nugget of gold because it can help you live in the community. So the last thing you want to do is lose your Medicaid, is lose your SSI, is lose your SSDI. But there's a problem. And everyone on public benefits knows it. That, as Forbes magazine said, it's pretty much impossible to have a good quality of life on public benefits. Here's why. When you're on public benefits, you're not allowed to have more than $2,000 to your name. That is called an income cap. And it's $2,000 of what's called countable assets. With very few exceptions, it means you can't own things worth more than $2,000. You can't have people give you things like free rent from your parents or a car from your parents without it counting against you. That $2,000 is often called a fiscal cliff, because once you go after the cliff at $2,001, you are at risk of losing the benefits you need to live in the community. So if Medicaid is your lifeline to healthcare and you can't have more than $2,000, that's a scary thing. Because at 2001, you can lose the thing that lets you be independent. But if you can't have more than $2,000, what kind of life can you have? But I hear people all across the country say they can't work. People who can perfectly be able to work and earn money and have experiences are afraid to work because they're afraid to go over the fiscal cliff. And that's why I want to talk to you about a program called ABLE. If you haven't heard about it yet, ABLE is an amazing program, relatively new. ABLE stands for Achieving a Better Life Experience. And maybe some of you have heard about a 529 account. A 529 account for education allows me to put money into a special account for my child or family member or loved one that then grows tax-free. And when the kid goes to college or whatever, they can take that money out without paying taxes on it. So it's a special account. ABLE accounts are 529s for life. Here's how they work. If I open up an ABLE account, I or my friends or my family members or anyone on my behalf can put up to $15,000 a year into the account. And that $15,000 does not count against the fiscal cliff. So you know how you're only allowed to have $2,000 to your name? Doesn't count with ABLE accounts. You can put up to $15,000 a year into an ABLE account, and it does not count against the fiscal cliff. And that money grows tax-free, and it can be withdrawn tax-free to pay for living expenses. We'll discuss some later. And the money in the ABLE account does not count against the fiscal cliff. So I can have up to $101,999 in my account, and it will not count against my fiscal cliff. When you get to $102,000, your SSI can be suspended, but you still get Medicaid. So if you want to learn more about ABLE, there is a great website called ABLE NRC, the ABLE National Resource Center.org. You go there and you can learn all about ABLE accounts, including how to apply for them. Because the ABLE eligibility is actually pretty easy. You are eligible for ABLE if you receive SSI or SSDI, or if you would receive it if you applied, only you haven't applied yet. So if I'm getting SSI or SSDI, or if a doctor certifies I would be eligible for it if I applied, I can get an ABLE account. So it can be as simple as a doctor doing a certification that said, I would find that this person is eligible for SSDI, and that would make you eligible for ABLE. And once you have an ABLE account, and again, ablenrc.org can tell you all about that, you can start putting money in that. You can start putting up to $15,000 a year in that to grow tax-free. Here are just some of the things you can use ABLE for. And I know there's lots of tiny words on your screen. Those are tiny words because those are the amazing things you can use ABLE for. Almost anything. Education, housing, employment support, healthcare issues like insurance, transportation like bus tickets or a car, moving expenses, life necessities like clothing, religious and cultural activities, vacation. The whole point of ABLE is to put people with disabilities in a similar situation as everyone else, the ability to have a life. And I always look at ABLE as providing a pathway. This is something that I know people who have used ABLE for. Now, I know one young woman in particular had this exact story. She was afraid to work. She was afraid to work because of the fiscal cliff. So this person who could have worked was afraid to do so and was sentenced to, as one expert calls it, a lifetime of poverty, because you can't have any money and you can't have a life. Well, this young woman opened an ABLE account and got a job, and she earned a little money. She put that money into the ABLE account where it grew. And what she did was she used part of that money to get additional education and job training. So she took it out of the ABLE account, which helped her get a better job, which helped her earn more money, which helped her put more into the ABLE account, which helped her get more education, which helped her get a better job. This young woman started at a minimum wage position in a hospital. And by earning money and getting training and taking advantage of ABLE, eventually worked herself into a full-time job with benefits. She didn't need public benefits anymore. Is that going to work for everybody? No. But what can work for people is having a little bit more money, having a little bit more opportunities to do a little bit more things. That's the whole point of ABLE, giving people an opportunity for a better life experience. You may have heard of something called a special needs trust. Those things work like ABLE with a couple of differences. One, special needs trust money do not count against the fiscal cliff. So that's a good thing. But the money in a special needs trust is taxable. Okay. And the big one on the special needs trust, you have to pay for them. Number one, it's not lots of them. You have to pay an individual or a bank to manage them. But really the biggest decision, the biggest difference is in a special needs trust, you have a trustee, the bank, the person, whatever, ultimately decides how the money gets spent. The person can ask the trustee for money, but the trustee can say yes or no. In an ABLE account, the person with disabilities, the account holder, decides how the money is spent. There's nothing wrong with a special needs trust. There's nothing wrong with an ABLE account, by the way. I have family members, one of whom has a special needs trust because he can do so many things, but he can't wrap his head around money. I have a niece, though, who uses an ABLE account. She is better able to manage money. So what happens is with ABLE, the person manages money, because the point of ABLE is to help people have a better life experience, to do more things, to do them in more ways. Well, if the point is to do more things and be more independent, then the whole point of ABLE accounts is to increase self-determination, to give more options, to give people better opportunities. And what better way to do that than making decisions, right? Making decisions about your money and getting support to do it. You can go on ablenrc.org and learn about how ABLE accounts can involve family members and friends in the decision-making process. Many states have it in their ABLE application where you can identify people right front and center who you want to be involved in management of your account and how you want them to be involved. You can say, I want my mom to have access to my account and my records to say where the money is being spent and how it's being spent. I can give my mom access to put money into my account. I can give my mom access to take money out of my account. It's my choice. So I could, and I've seen this happen, I can give people just access to see my account. I can say part of my disability is I spend too much. So I'm giving you access, Kate, to have access to my financial records to see if I'm blowing my budget. And if I am, I want you to have authority to take me aside and talk to me about it or freeze my account if that's what I choose. The whole point is, since I'm responsible for how the money gets managed, I'm able to designate how I want support in doing it. And financial issues can also be done through a program that we talked about before, Vocational Rehabilitation, the ORS program in Rhode Island. Remember that vocational rehabilitation, the whole point of it, in our last presentation, we said the whole point of VR is to help people work. Help people get ready for a job, get a job, keep a job, advance in the job, or get a job back. So if you need something or anything to help you work, then VR can provide it and must provide it. And that necessarily includes things like healthcare and financial planning. Because if that's what's keeping you from working, VR has to provide it. Remember that in Rhode Island, VR is the Office of Rehabilitation Services, or ORS. Remember that in Rhode Island, you have the CAP program through Disability Rights, whose entire job is to help people with VR issues. So you have a great advocate on your side for VR issues. And remember that VR has supported decision-making baked into the process, because every person in VR must receive the opportunity to exercise informed choice. It's right in the VR law. So ORS must ensure that every person taking part in its program receives information they need in ways they can understand it, so they can choose their job goals, their supports, and their services. In other words, supported decision-making is all about VR. And that through that supported decision-making, you can receive any supports and services you need to work. Just 3 of them that are written into VR's regulation are things like assistive technology, healthcare ones, for example, medical and mental health care, and services to family members, things like daycare and health support for an elderly parent or a family member who's not well. This is directly related to healthcare, and yet it's also directly related to work. And through the informed choice process, it's all about supported decision-making. ORS can also help you with fiscal cliff issues. Remember, you don't want to go over the fiscal cliff. So ORS can provide financial support called benefits counseling. Benefits counseling is there to help me work while at the same time managing my benefits. So ORS can provide me with benefits counseling to help me avoid going over the fiscal cliff. They can help me learn about ABLE accounts or use an ABLE accounts. They can help me manage my benefits and manage my finances to make sure I can both work and keep my benefits. Once again, through the use of the informed choice and supported decision-making process. So that shows you how financial and health issues, 2 of the most important we have in life, can help us through supported decision-making. Kate?
We have a question. Can a person have an ABLE account and a special needs trust?
State law issue. Again, some states say yes, some don't. I recommend looking at Rhode Island concepts. I've heard of it, and I certainly think if it's appropriate, it's great. I've known people who have transitioned from one to the other, but I would strongly recommend looking at Rhode Island specific procedures. But it'd be a good thing if you did, because you'd have more options. But some states limit it and say pick one or the other. So those are 2 areas that take us through life. But understand that everything we do, every decision we make, everything we go through in life should have that kind of review. Every power of attorney I write, every plan I write includes what I call a growth clause. Remember that young man who was 18 who thought he could be swindled and how they set up that plan through the power of attorney? We included a specific clause in that, just like I do in all of them, that says regularly, we're going to review this plan. We're going to take a deep dive into this power of attorney to see if it should be changed every year. Because our goal was for that kid to get better at managing money. The idea was if he was making better decisions, we would up his limit from $50 to $100 or $150 a month. If he was doing worse, we would downgrade it so he would be able to get more support. The hope was that after a certain number of years, he wouldn't need his mom's okay. It was to be a graduated growth process. And I think that's something we should have in every plan. Now, the plans you're going to have, like individual plans for employment or individual service plans in the waiver, they already require annual review. I don't mean that kind of review. I mean a serious deep dive. Again, looking at each and every goal and objective and support and service, and think about, what do I need? Have my needs changed? And that's a supported decision-making discussion, right? That takes us all the way through life, including end-of-life planning. When we're reaching the end of our journey, it's important to talk about it. It's important to figure out what we want at the end of life. And there are facilitated, free processes and programs, things called the Conversation in 5 Wishes, that can empower a person with disabilities to make those end-of-life decisions. Everything from, do I want heroic measures taken, to what medication I want, to what kind of music I want played at my service, or whether I even want a service. Now, people think that might sound icky, talking about death. And I thought it was until my dad was reaching the end, and how he felt a little bit better because he had some more control over something no one has control over. He got to say what he wanted. And we know that more self-determination is better. So I strongly recommend we incorporate that kind of support in everything we do. And what I hope I've shown you in this process is how supported decision-making is part of our life plan, birth to the end of the road. We've talked about special education from pre-K, and we just finished by talking about end-of-life planning. Supported decision-making takes us all the way through it. It traces a line through life. If we accept, and 40 years of studies say we have to accept, that self-determination makes people's lives better, then what we should be doing is finding ways to enhance that while also making sure people have the same rights, the same opportunities, not just to exercise rights, but to get the support we all need to do it. The studies are pretty clear. And the article of faith guides us all through it. People with disabilities should and do have a full and equal right to participate in all means of society and their lives. We can make that happen by empowering them to have that same opportunity that we have to make decisions whenever we can and get the support we needed. And with that, I'm very happy to answer any additional questions. That's my email on screen, by the way. Before we go to questions, please do feel free to email me anytime. Sometimes questions come to us after the fact. I know you guys have a storm coming, and so many of us are thinking, what's going to happen there? You may drop a question. I'm always available. These things have to be discussed amongst ourselves because someone's going to have a question that someone else has dealt with. So we need, that's part of supported decision-making too, having those conversations with each other so we can say what works, what doesn't, what we could try. And if I can help you figure that out, I'd be absolutely honored. So what kind of questions can I talk about?
I'm looking in the chat and I'm not seeing one.
Or you can also unmute yourself and just talk if you want.
Yeah, so this is John Souza.
Hi, John.
How are you? So I have a question. I actually would just like you to talk a little bit more to help parents think about how to respond to the doctor who says, well, your child has an IQ of 55, and I don't think anybody with an IQ of 55 understands the implications of this release that he has to sign before I'll do surgery. What should the parents say or do at that point?
Well, if at all possible, get a new doctor is my first advice, because that doctor doesn't get it, and that doctor probably isn't going to get it. But just as a simple matter, I always use the example of Jenny Hatch, had a tested IQ of 49. And she signed a consent to surgery and is just fine at it. Ryan King, who represented, had a tested IQ less than that. By the way, IQ is a terrible measure of decision-making. Think about every IQ test you've ever taken, if you've ever taken them. You either wind up in a place you've never been before, talking to someone you've never met before, doing things you've never done before, and that's going to determine how well you make decisions. Decision-making is experiential. Okay, I tell the story about Jenny all the time. The doctor I took her to, my expert, who I was depending upon to say she didn't need a guardianship, said, I tested her IQ, it's 49, she can't make decisions. And we didn't know what to do. And the doctor went, you know what, why don't we go to lunch? And he goes to lunch with Jenny, and he comes back going, oh my God, she made decisions all the whole time. She looked both ways before she crossed the street. She ordered her food. She paid. She counted her change. We had pleasant conversations. She took care of her hygiene. She didn't talk to strangers, and she did everything she was supposed to do. That's what decision-making is. Decision-making is experiential. It is something we learn by doing it. And if someone tells you that a number on a page determines whether you can make decisions, that is not someone I would want involved in my child's life for 1 second, because that's someone who simply does not understand what decision-making is. So I know it's not always possible to get a new doctor, by the way, but that's how I would answer it, is how do you know? And by the way, no one understands every page of that Hipaa release. No one, not me, not you, but you don't have to. That's why it's informed choice. I make a choice after getting information, and that information can be provided by me telling you what's on the form or explaining it to you in words you understand. You want a great example? Every time you're in the ER, look around you. You're going to see on the wall a piece of paper that has a bunch of faces on it, from a happy face to a really sad face. And it's what they use to triage people who don't speak English or who don't understand. They're asked to point to the face that represents how they're feeling. That's not understanding every single word. That's nonverbal communication that allows for support to help the doctor get the information he or she needs. And that can be done often by someone with an IQ below 55. So I would take that as an opportunity to educate. But if they say you got to understand every word on the release, I don't. I had surgery and I didn't like looking at that, and I'm a lawyer. It's about informed choice, what I understand after information, not about literal word for word choice. If it was about literal word for word choice, we'd all need guardians.
One thing that we've seen, and one of the parents, one of the attendees has noted in the chat, is that sometimes it's the anesthesiologist who wants the consent, and you don't know who that is until the day of, and that can be a challenge. I don't know that we have an answer for that per se.
I don't know that I do, except I would ask for policies in advance. I would ask what they do in advance. I would, whenever possible, if there's a supported decision-making system in place, I want to inform the doctor well ahead of time. If I've got a supported decision-making agreement, something in writing, I want to put it in the file. I want it stapled to the left front. If I have a power of attorney, I want it in the file. I want them to know in advance. I consulted on a case in Virginia where this exact thing happened, and they canceled a surgery that was really badly needed. And I said, "Sue, go to litigation. It's an ADA violation. It's a Rehabilitation Act violation because they got federal funds. Sue for damages." They sent a demand letter, and suddenly the hospital realized what they were supposed to do. Sometimes you do have to push back.
Other questions?
If nobody else has one, I have a kind of a related question. This is an area I know very little about. I know that the Social Security Administration has this questionnaire that's supposed to be filled out to help make some determinations about capacity. It seems to me that that's probably also a very inappropriate and not so very useful questionnaire. How does somebody challenge the use of that in the process?
I missed, we had a little connection hiccup. Can you state the first part of the scenario again?
So I don't know what it's called, but Social Security has a questionnaire that they use to determine whether somebody is supposed to have a representative payee or whether they can manage it themselves.
Okay. Yeah, and actually Social Security issued a report some years ago because I testified in the investigation on it, where they're supposed to be de-emphasizing representative payees, and supported decision-making was shown as an example of how a person could avoid having a payee. One of the things that Social Security is again supposed to do per their own policy is give people an opportunity to have a supporter on the phone with them. It's as simple as the person saying, "Yes, my mom is next to me. I want her on this call," so that a person can receive support through the entire process. A rep payee can be a very good thing, by the way. It can be something that can avoid guardianship. So I'm not discounting rep payees. I'm saying it's also an opportunity for supported decision-making through that questionnaire process, but also through the entire Social Security process. So I strongly recommend having a supporter on those calls. Just announce to SSA that you're going to have one.
I'm not seeing anything new in the chat.
Okay, well, I know that we're coming up on 7:30. So if someone else has a question, please feel free to ask. If not, please remember my email that I'm going to put in the chat box. And that you should feel free to reach out to me anytime. Hopefully I typed that correctly. martins@gmail.com. Please feel free to reach out. And I'm looking forward to talking with you again at our next time, when our next presentation is really going to be kind of a sum up of the things that we've learned thus far and ways to bring them together to create a more effective and efficient system. We're going to show you how we can fit supported decision-making to have the programs that you've heard about work together, get us out of siloed system. And one thing I'm really looking forward to talking to you about is something that we don't talk enough about, is ways that supported decision-making can help people be more involved in their communities and more involved in civics. Think about voting, for example. People with disabilities vote far less, statistically speaking, than anyone else. This is a great opportunity for education and experience. And I know that Disability Rights Rhode Island is doing some really interesting work around supported decision-making and voting. It'd be a great chance for us to talk about it when we get back together.
Wonderful. Thank you so much, Jonathan. And thank you for being available despite all of your hardships this week. We appreciate it so much, and we look forward to our next time together.
It's my pleasure. Thank you very much, and have a great night, everyone. I hope you all stay warm.
Take care.
Bye-bye.